Very good. So mitral valve disease. So mitral valve disease on the left side. Left side is more important than right side. So that's why aortic valve very important. And we said aortic valve in United States gonna be more important because of aging, but mitral valve it is more like the developing countries like Africa, India, uh, South America. But it is very important because uh, it is related to one disease that almost eradicated with penicillin, but it is the reason for getting this rheumatic heart. So we see that it is connected between left atrium, left ventricle, which means it lets the blood come from left atrium towards the left ventricle and doesn't come back. So the idea you have papillary muscles and chordae tendini, and those just seem like when you have like helium or gas balloon and you want to stick it to the ground, so you just put chordae to the ground so it doesn't go, it doesn't fly, right? That's how it do. It allows blood to go one direction and doesn't come back, so it keeps getting the circulation going from left ventricle to aorta to the body to the IVC, SVC, right atrium, and then pulmonary, and keep going circulation. So it is one time, like valve going one way, no comeback. All the valves are 3 leaflets, but the mitral valve is the only one that is bi-leaflets, and it is big one. We're gonna find it is 1/3 of the valve. It's gonna be anterior part, and 2/3 of the part will be in the back part, and it has 3 scallops, 3 parts. We call this one A, we call this one B. What are the causes? Number 1 is rheumatic heart disease. Number 2, mitral degeneration, aging, sclerosis, like atherosclerosis can be sclerosis. And third one is congenital. If you remember, when we said aortic is with on the opposite side, we said aortic valve stenosis. Number 1 is congenital, which is bicuspid. And number 2 is degenerative, which is sclerosis, aging, and calcification. And number 3, we put rheumatic heart disease. Now we put rheumatic heart disease number 1, and still degenerative is going to be number 2, and number 3 is will be the congenital. So this sequence is important in exam because in exams they ask you what is the most common reason, right? So you have to put this one. If you go in the aortic, you have to put congenital one. So question come like this. The most common etiology of mitral stenosis in industrious countries, which mean United States, Canada, and Europe, is still rheumatic. Yes, it's still rheumatic. You see, rheumatic is going to be more in India, Central Africa, and Central South America. But still, it is more in United States, going to fit more in the Midwest. Yes. Thank you. Yep. So what happened? We have it come. Someone has pharyngitis, sore throat, tonsillitis. Now we have something called rapid test, and this rapid test you can just go in 15 minutes. You check if the patient is usually school age, like 10 years old, and have this kind of streptococcus A. This one tricks the body because the body, instead of attacking the bacteria, will go and attack the heart, attack the kidney. So we're gonna find young kids get glomerulonephritis and starting having puffy eyes and swollen body, and some other can get affection to the heart. So how to diagnose this one? Early, you have to diagnose or patient with have sore throat and fever start having have joint pain. So when you have joint pain with sore throat, I start thinking about rheumatic heart. If it affects the synovial membranes of the joints, so it will affect the membrane endocardium of the heart and can give pancreatitis and inflammation and give some specific skin rashes. So as things go non-noticed for like 15 years. When this uh, young child go to the college by 21 years old, he found himself going into symptoms of mitral regurgitation or aortic regurgitation, and he need to go do replacement or those repair. Otherwise, it's going to go into complication, which is going to be heart failure, arrhythmia, and thrombus. We're going to see why all this can happen. So we cover this area with long-acting penicillin. They give them penicillin every 1 month, so you can cover from this 15 years old to like 21 years old, so you don't get this bacteria. So stenosis is going to be a narrowing of the orifice. You look here, you're going to find that it has more thickening on the tips, right? The tips of the valve. If you go in degenerative, it's gonna be more in the shoulders, which is gonna be more on the annulus. And this we call this one hepato. This one we call this one focal, and we call the other one is betal. So to differentiate rheumatic annulus is here, right? And the tips is gonna be here. So this one is rheumatic, and those are degenerative. So this differentiate because you look very similar. Both of them are thick leaflet. The other thing, yes, in the tips, right? So rheumatic also, if you have mitral valve rheumatic, you're gonna find other valves with it. But aortic valve stenosis, the degenerative could be just by itself. Vegetation come after because of like the rough surface will create degeneration vegetation with bacteria like weak bacteria on this vegetation, and we're gonna discuss this one when it comes to embolus. What is the complication? Is embolism, septic embolus coming from the vegetation. So let's go first step, which is the normal anatomy. So we say normal anatomy, we're gonna be by leaflets. We're gonna have anterior left short. It has 1/3 of circumference, and the posterior one is long and have 3 sections called the scallops. We have papillary muscles. Which one has more vulnerability to get like flail or perforation, or it's gonna be P2, which is the middle part. It is best if you do it with 3D or with TE, you're gonna get better and close images. So the first picture you can see here, what is the first something you can see on the echocardiogram is gonna be the doming. You remember we said doming a characteristic in aortic stenosis was bicuspid valve, right? Here it's gonna be just we have mitral stenosis, it's gonna have doming because the blood try to go into through the stream of the valve and it doesn't find enough space to go, so it keep pushing on the sides. We call this one doming. So one of the signs to know that this is mitral stenosis goes the anterior leaflet, but sternal long axis V, you find it is giving doming. Look on this one. Second thing you're gonna have beside doming, we're gonna start having fish mouse. Why fish mouse? Because we have something called tethering. Tethering, it means that all the tips will be attached to each other, like cooked together with the commissure, which is the angle of the mouse. So we're gonna find this, both angles are fused and have the tethering, which is cooking all the tips together. We'll call this one tethering. And give fish mouse. So these are the two features you can see in on echocardiogram 2D echo. It is less mobility, and we see that the thickness on the tips, and it has narrowing of the opening. Mitral annual calcification or degeneration, this will be the edging, it's gonna be more wear on the annulus, right? We call it petal. Yes, it's thickness or thickening. You see here look like thickening too, but thickening is close to the shoulders, not on the tips. This is the tell me that this is a degenerative disease. Congenital. We don't have that much congenital, that's why we put it in the third part, and we call this one, we have two of them, one called parachute and the other one called bicuspid. You look on the right side, you see two cuspids, bicuspid. These are the two congenital. It's not that common like it is in aortic for bicuspid. So heavy stenosis, it means the blood keep pushing on the wall of the left atrium. We call this pressure overload. So pressure overload, it happens with stenosis, but volume overload happens with regurgitation in any valve. Volume overload with regurgitation. Like when it's coming back, when you have the valve wide open, so the blood keep going. I send blood from the left atrium, it go back to the left atrium again, and this is gonna be volume overload. More blood. I send the blood out from the atrium to the ventricle, it come back to me. Volume overload. Mitral aortic, the same thing. No, pressure overload mean I have stenosis narrowing here, so the pressure to send the blood here will be distributed on the wall, right? And then by the time it can be distributed back to the 5 pulmonary valves, pulmonary veins to the lung, and will create pulmonary hypertension, congestion. So another value, we're gonna say that if you have mitral or left side problem, you get pulmonary hypertension. But if you have right side problem, usually get liver congestion, which means right side heart failure. Liver congestion with other consequences like edema, swollen ankle, pleural effusion, pericardial effusion, ascites, all this followed because I keep sending blood from the IVC, SVC, and still the garage is full. So liver congestion, yeah. So usually when you start with stenosis here and the blood back up, it's gonna back up to the 4 pulmonary veins, go to the lung, make lung congestion, and then it's gonna, by the time so many years, start having instead just congestion, and sometimes get pulmonary edema, which is emergency, get Lasix and start to decrease the load on the heart. By years, it's going to be peeved. Too much time with pressure and gonna be disturbed the whole structure of the lung, start to get beefed, something like beef, like it is not something like sponge with alveoli and air go back and forth. So when the pulmonary try to send the blood to the aorta, to the lung, it doesn't go through because this one is beefed. So it's gonna back up, and back up, it's gonna come to the other side of the right side of the heart and give all this stuff on the other side, which is gonna be on the right side failure. So, and what is our window to know that severe mitral stenosis is happening is that start having pulmonary congestion and then pulmonary hypertension. To say severe, it has to be pulmonary artery pressure, pulmonary hypertension, increases pulmonary artery pressure. So when this happen, what is our window? You see our window, you go look on the tricuspid valve. If you find tricuspid valve regurgitation more than 2.8 meter per second velocity, this means I have pulmonary hypertension. Of course, with the technology, we start having speckles and we can assess just the myocardium. We can have more advanced to evaluate right atrial heart failure. But these are the tools that we are using on our TTE, which is going to be more in our hand to make tools to diagnose. So now we have no pulmonary tricuspid valve on the right side, tricuspid regurgitation on the right side of the heart, right atrium, right ventricle. Because have pulmonary hypertension, I try to send the blood through the pulmonary arteries. It come back and then give regurgitation. I'm gonna go both. Yeah, I'm gonna go on the right side to put sample volume to check the regurgitation velocity. If this regurgitation velocity more than 2.8 meter per second, I say this mean I have pulmonary hypertension. What does that mean? It means that I have severe mitral stenosis, right? This tells me that one is severe. Why? Because it's severe, it turned into the lung, and after so many years, turned it on the right side. Now I have left atrium, left right atrium, and right ventricle. All those are congested, right? This it means severe. It switched from left side, affecting the right side. Like you have 3 tires of the car are down. Yes, this is our window. So this is mitral stenosis. It affects the lung and then affects left atrium and right atrium. What's our window to detect this stenosis? I go on the tricuspid valve and measure the velocity. I find regurgitation more than 2.8. Then I know this one has pulmonary hypertension and I know that I have severe mitral stenosis. Generally, any problem in the left side, when turned to the right side after so many years, it means that start the left turning into right side. This is going to be congestive heart failure. Mean it is going to be on both sides have heart failure in future. When you have 4 chambers, we need to do cardiac transplant. So once it is left and then turning affecting the right side, this is bad sign. So how does mitral stenosis affect left atrium? We said if the left atrium have stenosis sphere, so what happened is narrow. I get started blood pressure distribute onto the walls. I get what? What happened to the left atrium? Yes. What is the result? What I'm gonna see on the echocardiogram? I see dilated left atrium. Dilated left atrium. Very big left atrium. Symptoms, of course, we said when you have back up to the lung, I'm gonna have pulmonary edema, pulmonary congestion. So everything on the hearts, usually, especially heart failure, you're gonna find short breath, number 1. Number 2, you can find fatigue because I have not enough blood going to my heart, to my body. And then later on, I can get hemoptysis, which is spitting of blood because I have congested lung. And those later on I can have chest pain because I have decrease in the coronary going to the to the muscles. So what are the 7 physical findings for mitral stenosis? We have something, we hear it with the stethoscope with the doctor called Ramberg-Medmar. We have something called opening snap, the same like when have bottle of champagne, and then you see that when you open it, it's gonna just make something like. So the normal heart would give lap dub, first sound, second sound. So we're gonna find this one snapshot, oblique snap after the second one because it have very tight mitral valve. Have atrial fibrillation. We're gonna see why I have atrial fibrillation. We have short breaths. We said why? Because we have lung congestion. We have fatigue because not enough blood going to the heart. We have orthopnea, which is the patient cannot lie flat. He has to lie into 45 degree because if lie flat, it get congestion, right? And we have split blood because it's too much congestion. So it has a lot of stuff on the lung side. Still, we don't see anything. What we can see that what is happening on the valve. So what happened in the valve, it's gonna be, we see tethering. So why you have atrial fibrillation? Because if you have the left atrium, you have SE node, and then have left atrium, then we have AV node, and then we have left ventricle, right ventricle, and we have something called bundle of His, distributed on both sides, and so the distributes the electricity the same like when you have wires in your home. It's gonna go to the two rooms, then gonna go to this one switch to go to the ventricles. It takes some time to let the atrium squeeze all what has into the ventricle, then the ventricle will start contracting. This cords will be ripped off because of dilatation, right? Dilatation, if stretching from each other, get ripped off. We're gonna find that at the end, the left atrium work by itself, left vertical work by itself, left atrium work by itself. I get atrial fibrillation, which means I get a lot of B's and gain what QRS, a lot of B's. I don't know how many I get QRS, so I'll work on separate. We call this atrial fibrillation. Pulmonary edema, congestion give pulmonary edema. So left side of the heart give pulmonary edema, right side of the heart give peripheral edema. So pulmonary edema, this one need a lot of Lasix and diuretics to get the fluid off the system. What you see in 2D echo, left atrial enlargement, tethering, which means gonna be cooked, the tips will be cooked. Fish mouth, thickening of the leaflet, decrease the mobility, decrease the opening, and then pulmonary hypertension, right atrial enlargement, right ventricle enlargement, which means it is signs of severe stenosis. A feature of mitral stenosis, doming of the anterior leaflet, right? Commissures will be angle of the mouth is fused. Thickening of the leaflet of the tips, which is, we call it tethering. Restricted motion. We can find other valves with it. Then end into the lung, give pulmonary hypertension. Then on the right side of the heart, give right-sided heart failure. How to know this process is going from bad to worse? I check the tricuspid valve. I see the tricuspid regurgitation is more than 2.8 meter per second velocity. This is our window for now. But now we have the speckles, the tracing, which, so we can have advanced, we can make this evaluation. But what is the tools in our hand? In the echocardiogram, I don't see something on the lung. What I do, I just go to the tricuspid valve. This tells me that I have something wrong in the lung, coming to the right side of the heart. I'm going into total heart failure on both sides. Atrial fibrillation, because it is like shaking, the whole shaking, and we have the left atrial appendage is going to be like dark room. I can have thrombus in the left atrial appendage because it is like dark room, and this atrial fibrillation, there is no such movement of bloodstream of the blood. So these are the features: doming, tethering, left atrial enlargement, doming and thickening in the tips of the leaflets, less mobility and narrow opening, commissure fusion, where this not, no, this is the parasternal short axis view. You have the right ventricle here, you have the septum here, you have the mitral valve here. So we're gonna find that the mitral valve, it is tethering, which means thickening of the leaflet, the tips, and the angle. When you go in parasternal short axis view, you take levels. One level you can come at this level at the mitral valve, right? You go from the top here and have the aortic valve, and you keep going taking levels up to the apex down. One of them you have to focus on the mitral, and you're gonna see this. It is in the tips, but this is can be transverse section slices. This one longitudinal in parasternal long axis view, you can see it very clearly. It is in the tips, but in transverse, when you go transverse, it can be take just sections when it is rounded. Just take one section. The heart is like this, and it keep taking sections like this, right? It be like circles. When I come to the level of the mitral valve, I start seeing it here, right? And this is how it looks like. It is. I'm just making like focusing on the orifice itself, the mouth, to something like the mouth, and have the angles. So I'm gonna come in this level. I take the picture only at the level of the mouth. This still in the tips. So now we have. You remember we said aortic valve area. We said aortic valve. We have three factors to decide how severity of the stenosis, and we said we have the cross-sectional area, and we have the pressure gradient, which is difference between two pressure gradient, and we have the velocity. And here we have to know the normal first. The same thing will happen here. So the normal velocity is 0.9. We're going to say range between 0.6 and 1.4. You have to remember this. And then what is the pressure gradient? It is 2 meters per second, which if you have valves here, so the pressure in P1 and P2, this one has to be bigger than this one to push the blood in this direction. We call this pressure gradient, difference between pressures, which means P1 minus P2. This is called pressure gradient, delta P, pressure gradient, which means difference between both sides. And this difference, I cannot measure it with echocardiogram, so I have to do something indirectly. So we have Bernoulli equation that will decide for us how to do this by using the velocity. All of us can measure the velocity, right? It is easy. You can just restrict the sample volume and measure the velocity. Now I say I want to do pressure gradient. I have only velocity. I have Bernoulli equation, which will help you to decide what is the pressure gradient. Continue equation. I cannot cross-section area. I cannot do the measurements. It's 4 to 5. I have something called the continuity equation that will put the velocity into equation to give you the cross-section area. The same thing when we did in the aortic valve. Changes in doppler. We're going to say high velocity. We can use pressure half time to see what is the cross-section area in easy way with aortic mitral valve area. But you need to remember the numbers now. We said the velocity is 0.9, and the number between 0.6 to 1.4. It is 0.6 to 1.4, when the average is 0.9. When you come to the gradient, it is 2. What is the abnormal one? We said in aortic, we said the normal aortic stenosis, the normal pressure gradient is between 2 and 4 millimeter mercury, and we said between 20 and 40 is moderate. Less than 20 is mild, more than 40 is severe, right? Here's the same thing. We're going to say that something different numbers. We're going to say that between 0 and 5 is mild, 5 to 10 is moderate, and more than 10 is severe. Okay. What about this? What about the velocity? Velocity is going to be something very similar. 1, 2, 3, 4, 5. We look to the tricuspid valve to see how severity of the mitral stenosis. Why? Because if I have severe mitral stenosis, I get pulmonary congestion, I get pulmonary hypertension, then I get right side heart failure. what is my window, gonna have pericardial regurgitation. I measure it, it's more than 2.8, so I say if this patient has pulmonary hypertension, it's getting from bad to worse. I'm gonna, if it was left side, it's gonna be right side now. What other thing you can see, go parasternal short axis view, you see they have flattening because the right atrium start getting bigger. So usually the left ventricle is just keep moving, the crescent is rounded. Now because I have big right ventricle, I start having flattening. And this flattening mean I have start having right side heart failure. This another feature. Tell me I start getting from left to pulmonary hypertension to right side. Thrombus. Yes. The normal is 2. We're going to say between 0. We're going to say 0 to 5. We're going to say at least less than 5 would be mild. So we go for, because we have atrial fibrillation, we said because the electricity is not connecting the all rooms together in synchrony. Because starting the atrium is going to be just something like shaking, and this shaking is not pumping or pushing or blood flow, so it's going to give thrombus, blood clot. The same when you have like pool, and pool is not moving, nobody swim there, no change of the water, you're going to find something just built on the walls. The same thing here, which is going to be the thrombus. So we have to differentiate between thrombus and there's something else, it is cardiac mass. How you know this thrombus or cardiac mass? I show you the difference. Difference is we have this cardiac mass, it can be something, the most common one is myxoma. And the myxoma will be more to close to the foramen ovale. This is the foramen ovale will be here. It's gonna close to the septum. But the thrombus will be more close to the the left auricle, which is gonna be have the dark room, left auricular appendage. This is the thrombus. It's gonna be by the appendage, right? But that mass will be by the septum. That's number one. Number two, this one will be darker, but this one will be brighter. Right? Will be more brighter. The mass will have smooth surface and lobulated. This will be like just irregular. It is just something stick to the wall. The mass can be pushed, can be fall into the mitral valve and mimic mitral stenosis because it's gonna go and block the passage. Thrombus will not do that. Thrombus will be more common with atrial fibrillation. This will come with more with just would be more congenital. Thrombus can give, yes. It's like polymorphic, it can have different shapes depending on the attachment or depending on the blood clot. Polymorphic mean different shapes. The thrombus can give embolus, can just break down into embolus and start go to the brain and give stroke and go to different places and give infarction. But this one is going to be more going to block the mitral valve. So hemodynamic would be more on the mitral valve in hemodynamics. You can just see the read. So this is the thrombus you see in the left atrial appendage from different views. Now we have to M mode. How it looks in M mode. M mode. To read M mode, you need to know what is the basic for M mode. We said that, and it was the M mode was originally the echocardiogram before 2D was developed. So it was the only one used. So we have the parasternal long axis view. I have the mitral aortic valve here. I have the mitral valve here. So what I do, I'm gonna go on to the mitral valve and put the line here. Or when I do the aortic, I put it here in the valve. I see how the movement of the valve. So we said in the aortic, it's gonna be something like diamond shape opening and closing, and this during the opening. And if you have any degeneration, you're gonna find just have thick walls, right? So you can know that this is stenosis, right? But the normal one, thin and nice, and it feels like 25 years old, which is gonna be uh, nice and slim. If you go for mitral give you something very similar or close to the EA ratio. It's gonna give me the movement of the valve EA, and gonna have the same thing on the back, but I'm gonna focus on the EA ratio. So I'm gonna say this E, this A. We call E when the valve open and the heart is filling filling the left ventricle spontaneously. So this one is left ventricular filling. And then after I fill all the blood in spontaneous, whatever left in the atrium will start making contraction, systole, atrial systole, to get whatever left in the atrium into the ventricle. Right. Atrial systole, to push whatever left in the atrium, squeeze it to get every drop into the left ventricle. Just A, which mean atrial systole, which is contraction. Systole. This is filling. Then we're gonna label them so we can just do something on the valves. We're gonna say the beginning here, we call this one D, which is just to start the opening of the mitral valve, and we'll call this one F, which is the end of filling, and we're gonna call this one C, which is the end of the cycle, and start having into relaxation. So what is happening with stenosis? We're gonna look into this slope. If this slope started changing like this, it means I have stenosis. I have more stenosis, right? So I'm gonna be like this. It means I have severe stenosis. Work only on the slope. If you look on the other slope, the other slope is gonna be this one. This one will call it the deceleration time. I measure from here. I measure the timing. Just to take the slope to measure, but I measure this time. I measure the timing. We're gonna talk about this one when it comes to time. But for now, this is the M mode. M mode, it has D point, which is initial opening. E is ventricular filling, and F is end of filling, and A is gonna be the systole, and C will be the just closure. So what happened? No, you just focus on it is mitral valve opening, right? This opening and this is closure, right? Here we gonna be closure. So we have here closure, we have here opening, right? Still, this is not what we're looking for. What we're looking for, we're looking for the slope. This slope will tell me if I have stenosis or no. So I just focus on the slope, and we're gonna find EF slope is decreased. What does it mean? Now we know why we label them, because we're gonna say EF slope is decreasing and the E amplitude is decreasing too. And this is what we have. This is the normal one. You see E and A, right? You come here, you see that it is starting the slope, which is we're focusing on, which is this slope. This slope is going this way, right? Instead of what this way. See, this mean I start having decrease in the slope, and this is mitral stenosis. And this slope get less slope, I mean I have more stenosis. So this is why you call this one severe stenosis. So this is the difference to this American Society of Echocardiogram. You see some nice talk about aortic valve and mitral valve, or how they look like. This is a normal aortic valve, and you can just review those. You can freeze and read if you want, and less angle. I mean less slope. Like this is normal. If you get like this slope, this will be a stenosis. Normal is like this, right? It's gonna be something like this. Okay. Yeah, that's it. Decrease in the slope, right? This is the slope, and it's gonna be decrease in the slope. It's gonna be like this. This decrease in the slope, right? Yeah. Now we go with our aim at the end to measure a mitral valve area, which is everything. This was going to tell me if I have stenosis or no stenosis, how severe is stenosis. It's going to be the same like aortic. Still, we know the normal 4 to 5. Aortic we say 2.5 to 3.5. So now 4 to 5. Still, they're going to have the same standard. Between 1 and 1.5 will be moderate centimeter square, and more than 1.5 will be mild, and less than 1 centimeter will be severe, which means if you have the opening like this, if this opening like this would be severe, this will be mild, like this will be moderate mild, right? So the big one is mild, the second one moderate, the small one is severe, depending how measure is the diameter, right? So this how do this degrees. How to measure this? Exactly. So you say if you measure, the best measure is to do the planimetry, and the planimetry you just go in the parasternal short axis view, and I showed to you, and we said we're gonna freeze at the level of the mouse and start making tracing, and you see how is the opening. This is the best one. We don't do that in any protocol in TTE. We do it more now with 3D and with TE, not TTE. Not with thoracic. We do it with esophageal. So for us, how to we do it with 3D planimetry or do it with transvaginal echo. So what we do for on our side, we look with eyeball. So eyeball, you can see it is mild, it is moderate, right? It is severe. You look for parasternal short axis view when you start seeing the mouse itself. So what other easy way we use it to do the aortic mitral valve area? We have to use the pressure half time. The pressure half time, I'm gonna still work on the same slope, right? We're gonna work on this slope because I know this one tell me if it start having stenosis, right? So I'm gonna work on this slope with regurgitation. So we're gonna go regurgitation, take the slope, and this slope will give me, the machine will give me how much pressure half time. I take this number, put in the bottom, pressure half time in the bottom, and I put on the top, I put 220, calculated number, and this will give me mitral valve area. So the machine will do a calculation for you, but still in the exams, they want you to know that you know how to do it. So we're gonna see what's the slope here. It gave me measure half time 163. I put 163 on the top. I put in the bottom, I put 220 on the top, and this will give me 1.3 centimeter. So 1 centimeter square, and this area is between 1 and 1.5. I call this one is moderate stenosis, right? Yes. So what is asked in the exam, what is the most accurate method? You see planimetry. What is the easy one? It's gonna be the pressure half time. The pressure half time is just need that you have so if you measure bit 1.5, this between 1 and 1.5, this still this moderate, right? And you keep doing the measurement with the pressure half time. This one, what is the pressure half time? The question put 220 over pressure half time. So you do it here. You find this one is 120. You put 120 on the bottom. You put 220 on the top, and this will give me the mitral valve area. And this is the pressure half time, right? What I just measured it, which is this one. I put it here. I put 200 on the top, and this will give me 1.8 centimeters. So 1.8 is more than 1.5, which means this is mild stenosis. We keep doing, and whatever number come, we're gonna put it into the table that tell me what are the size, what is the diameter, and we can short. What's the most accurate one? Planimetry. What is short axis, parasternal short axis view? What is the easy one? Pressure half time. So this is the table. You say between 1 and 1.5 is moderate, and less than 1 is severe, and more than 1.5 is mild. You go pressure half time between 5 and 10 is moderate, less than 5 is mild, more than 10 is severe. And we keep deciding on what is the severity. Velocity is going to be the same thing, 1, 2, 3, 4. This is the deceleration time, normal between 150 and 250, and we work on this slope, this area. We don't work on this one, work on this one now. And this decide if I have diastolic dysfunction or have a cardiac cardiomyopathy, which is the restrictive one. You remember we said E ratio in the restrictive one. If you have the normal one like this, if I have reversed like this, will be diastolic dysfunction. If I have exaggerated, doubled, more than 2, we'll see this one is going to be restrictive cardiomyopathy. If I have the slope get straight like this instead of gain angle, this means decrease in the deceleration time, and this would mean I start having irreversible restriction, which is going to be more severe. So the last part on this one, we have to work about Wilkins criteria. And Wilkins criteria, it is just this tell me if this valve is still soft, I can do balloon and do stent and stuff and do dilatation, repair, or it is very sticky and it is very hard like rocky with calcification, a lot of fibrosis, so I have to do replacement. All the time it is better to do repairs than do replacement. So we have Wilkins criteria tell me this one. They put 4 factors. One of them, what is the mobility? What is the thickness of the leaflet? What is if any classification? Any thickening below the subvalvular? This is the severest one, right? And then we put them into 4 from score between 0 to 4. I keep looking. Mobility look like 2, thickness look like 3, and calcification look like 1, and then I see thickening subvalvular doesn't exist. Then I put score. I collect this score. The all score 4 by 4 is 16. So this is a score depending on every item into 0 to 4, and whatever is the number is number total 16. If I get less than 8, this means it is pliable. It means it is still soft. I can do a balloon and the transplant and the repair, which we call it percutaneous ballooning valvoplasty. No, this is different. Decision time is only for the restrictive and for the diastolic dysfunction. This finish. This one is criteria to decide do surgery or no. This has notion to decision time. This another topic. This topic, this valve, I want to do it. Can I do surgery or I better to do just ballooning? And this criteria tell you if I can do, if this you give the score less than 8, it means I can do ballooning. More than 8, I have to do replacement surgery. Yes. PMBV. For metal valve. So this from American site, you can just have a look how it looks like. You can just have some reading, and we'll have to do some questions. Ready for the questions? Yes? Why what do you mean no? I want to see if everything is okay, okay? I am sure everything is okay. Let's start with the first question. What is the most common cause of mitral stenosis worldwide? Yes, correct. Rheumatic heart disease. What is the hallmark echocardiographic feature of mitral stenosis? 2D. Echo. Correct. Very good. You see, you can do it. What is considered severe mitral stenosis in valvular area? Which one of those severe? We said we have mitral valve area, we said we have the velocity, and then we have the pressure gradient. It is D. Our mitral valve area less than 1 centimeter is the severe one. More than 2, it is means that it is more than 1.5. This is mild, not severe, right? Between 1.5 and 2, still this one is more than 1.5. Still this one is mild. So those are wrong. Between 1 and 1.5 is moderate, right? So those are mild, and this is moderate. So the whatever left is gonna be this one, which is less than 1, is the severe, and this is the criteria for the mitral valve area. What is the typical shape of the mitral valve in severe mitral stenosis with 2D? The shape. You look the keyword, the shape. Yeah. So it is fish mouth appearance. Yes, correct. Which doppler measurement is used to estimate the severity of mitral stenosis? Pressure half time, correct. What is the typical symptom of mitral stenosis? We said all the time in heart, usually number 1 is, like 90% of the time, is short of breath and fatigue. So it's gonna be this one, right? In mitral stenosis, which chamber of the heart typically enlarges first? Which one enlarges first? Left atrium. Yes. What is the normal mitral valve area for adult? Normal. 4 to 5. Which condition commonly complicate long-standing mitral stenosis? Pulmonary hypertension. Applaud. What is the characteristic murmur of mitral stenosis? This is a more just look for the keyword. It is more clinical with stethoscope, but it has something for us to called. Exactly, opening snap. You make connection. Yes, very good. Which echocardiogram view is best to evaluate mitral valve morphology? I said it. Which one I can see the fish mouse? I said I have to go in the parasternal short axis view. I take multiple levels from the base to the apex. When I come to the level of the mouse, which is the mitral valve, I start taking my shots and measure and put the color doppler, see how the jet looks like. I take picture 2D to see the fish mouse commissures, which will focus more on the tips of the valve. What is the rule of 3D mitral stenosis? Exactly, valve area. What is the pressure half time more than 220 indicate? So if you put 220 on the top and you put our pressure half time measurement 220 on the bottom, what I get? Yeah, I get severe because it's gonna be less than 1, right? If I get this one more than 20 or see 220, still this will be less than 1, right? So it's gonna be severe mitral stenosis. Mitral stenosis, which Doppler parameter helps determine pulmonary artery pressure? Which one is our window to go and try caused regurgitation velocity more than 2.8? I say this one has pulmonary hypertension. Which of the what echocardiographic sign indicate left atrial enlargement? Okay, I got this one because I don't focus too much on diameter because American Society of Echocardiogram gave you cards with the numbers, but it is 40. Which of the following can mimic mitral stenosis in echocardiogram? Myxoma. You remember I said just to the septum and can go just to stick into the mitral valve and close it. When you said differentiation between myxoma and uh, thrombus. Which treatment option is appropriate for symptomatic severe mitral stenosis with pliable valve? Balloon valvoplasty, exactly, because still soft, yes. Which findings suggest mitral stenosis with associated mitral regurgitation? Both together, one going, one back, stenosis and regurgitation. When it comes back from the ventricle, it pushes through the four pulmonary veins. Reversal. What condition can develop secondary to long-standing mitral stenosis? Active fibrillation, correct. Right answer. What is a key echocardiogram feature of rheumatic heart? Echo. Mitral. How to know this one is mitral? No, vegetation is something very late with endocarditis. Fissures, we're gonna have the mouse. Mouse is gonna be tethering, which is thick, but we're gonna have the fissures, commissures are fused. Yes? Commissure fusion, which is the angle of the mouse. This will be fused, make the opening smaller, right? And give me the fish mouse. So it is part of the peripheral system, which is the steps of the mitral valve. What's the primary cause of congenital mitral stenosis? I said two of them: parachute and double orifice, right? Mitral stenosis, what causes characteristics opening snap? Why you have opening snap in auscultation with stethoscope? Stiffness of the mitral valve, which is the same opening of the bottle of champagne. Which of the following best describes the hemodynamics consequences of mitral stenosis? Increased pulmonary venous pressure, pulmonary congestion, right? In mitral stenosis, which chamber experience pressure overload? Yes, left atrium. What is the main indication for percutaneous balloon mitral valvoplasty? Pliable. What echographic feature suggests poor outcome of valvoplasty? We said we have mobility, we have thickness, we have calcification, and we have subvalvular apparatus thickening. So this is gonna be this one, right? The worst one. What is the most reliable echocardiogram method of determining valve disease, valve area? Which one? The best one to measure the valve area? Yeah, this is the easy one. This is the accurate one, but we do it with 3D or TEE is much better. We don't do it with TTE anymore. What happens to the left ventricle function in isolated mitral stenosis? Left ventricle. Not touched, right? It is not touched. We have dilated left atrium, pulmonary congestion, right and left ventricle, tricuspid regurgitation, liver congestion, and edema, peripheral edema, right? What significance of transmitral mean gradient more than 10? Pressure gradient, difference between P1 minus P2, called the pressure gradient. Pressure difference, we said the normal is, so more than 10 indicate what? Severe. Pressure gradient we see between 0 and 5 is mild, 5 to 10 is moderate, more than 10 is severe, right? This one is more than 10, severe. Which is the following is potential complication for matic during pregnancy? Complication during pregnancy, what can happen? Pulmonary edema, correct. Increased blood volume during pregnancy can precipitate pulmonary edema and mitral stenosis. What is the main consequence of long-standing mitral stenosis, long time, on pulmonary circulation? Pulmonary hypertension. Very good, applaud. What is hack stick appearance? Rheumatic mitral stenosis. The same. It is the same like. It is the same like doming, but different shape, right? It is the same like doming. Correct. Same like doming, but it gives sick like. It is the same like hack stick, right? Same thing. Which scoring system used to assess suitability for ballooning? Which system? Yes, Wilkins, correct. What is the typical heart sound associated with mitral stenosis? Opening snap, correct, upload. What is the main effect of mitral stenosis on cardiac output? Decrease, of course. Mitral stenosis reduces cardiac output due to distraction of filling of the left ventricle. I try to fill the left ventricle, it is closed. I don't have enough blood to send out, so decrease cardiac output to the body. Which imaging modality can provide additional assessment for mitral stenosis with transthoracic echo? Is not working. What should I do? TE, yes. What is the Eve wave deceleration time in severe? More than 300, yes, correct. Which valve condition is often seen alongside mitral stenosis and rheumatic heart? I'm gonna have all of above, correct. What is the role of anticoagulant, blood thinner, in mitral stenosis? Why you put blood thinner? Thromboembolism. AFib can cause thromboembolism. What cause? Okay, this one double density. This just something from the clinical with doctors. Left atrial enlargement. You can freeze it if you need more information. Which procedure is definitive for treating severe calcified mitral stenosis? I'm sure this one is hard one, Rocky. What should I do? No, I do this one if it is pliable, which means it is soft. When it is hard, I do replacement, right? Which of the following can be sign of right heart failure in mitral stenosis? Yes, right give peripheral edema with liver congestion, left give pulmonary edema with pulmonary congestion, yes? What is a common arrhythmia associated with mitral stenosis? Atrial fibrillation, yes. Last one, in severe mitral stenosis, what happened with pulmonary capillary wedge pressure? It means I'm gonna go put swan tube into the pulmonary and vasculature and see if the pressure increase or decrease. It is increasing. So do the left atrial pressure. I'm gonna put pressure back on the pulmonary hypertension, right? Pulmonary congestion. You're gonna have the pulmonary capillary wedge pressure will be increased. So So let's take break and come back.